what's unusual about our talk tonight is we're going to actually really reframe the conversation from the viewpoint of a person who's going into the hospital to give birth and wants to remain in control of their identity and their experience. And I want to talk to you specifically about how much control does that person truly have to kick off this conversation. I want to have just a real discussion with you in terms of that person who's walking in, choosing a facility to give birth in, and the reality of the control that they're in terms of the situation, in terms of the birth outcome, and even in terms of the education and information that they're provided with to really enhance their recovery and function. And so I think if we can actually have a true open discussion about what actually goes on in the hospital, then we can really move forward and talk about the education and information that's not being given and how we can actually change that narrative. Welcome to this discussion.
Thank you. Thank you for having me. I mean, this is one of those conversations that I think a lot of us are having with each other and with our individual patients. And I'm thrilled to have the opportunity to have it on a larger scale for those who don't necessarily have the experience or who want to gain more insight to how to really empower patients in the very, very earliest postpartum minutes and hours and days.
Oh, exactly. Minutes and hours. Let's talk a little bit about that. I want to talk about a particular person that comes to mind who was rushed to the emergency room, did not know really what her outcome would be because her mother did not know at the time that she was pregnant. And so she was in horrendous pain. And about 36 hours later, after a cesarean section, her mother wanted to forget the whole experience, at least from her daughter's point of view, who was pregnant against her will. And so that experience fundamentally changed how I approached this topic and how I taught therapists to prioritize recovery for people in the hospital, which led to me understanding that we could no longer be in control of the information and education that they were given. For this young girl, her priority was just simply getting in and out of bed without pain and having her breasts not hurt from being filled with milk, that she did not want them to be used for that purpose. Her identity was fully involved with her school, with her friends, with her activities, with just growing up and being a child. They were not associated with being a mother at the time that she gave birth. And so, in terms of sexual wellness and sexual health and sexual identity, I think that we need to first lay a foundation for people to understand that that's an activity, it's an identity, it's relationships. It is something that, one, we are to prepare people for something that is so fundamental to their joy and to their experience as a human being, and to deprive them of information that they need to succeed physically and mentally. I think that would be one of the greatest disservice that we can give to someone who chooses to go into the hospital, undergo a major surgery, give birth, and then be deprived of information that's going to allow them to heal. And so I want to ask you, and kind of reframing this conversation about sexual health and wellness, I want to, right, at least for the audience's understanding, kind of redefine what sexual health means, especially with this population, because we're going to go broad, but then we're going to go very deep and specific to individuals who may be represented in this room, and then to individuals who never get a chance to walk into a pelvic health therapy clinic weeks afterwards when maybe these conversations would quote unquote be more appropriate. What is sexual health?
It's a it's a bit of a misnomer, I think, and I think about it, if we're going broad, the way that I come back to sexual health is that it's not necessarily the act of intercourse so much as it is the wellness of the organs, the sex organs. And that's also how I look at the menstrual cycle. I I I really I bristle at the framing of an onset of menses when people say it's your body's now ready to give birth, because that's happening to 9, 10, and 11-year-old bodies, and they are most certainly not at that point physiologically ready to give birth. So I look at that onset. Actually, what it is, the introduction of estrogen is the beginning of the preservation of bone health, muscle mass, accruing muscle mass, and bone density. So even when we talk about and we define sexual wellness, I really think we need to think about it as like the wellness that comes along with the endocrine system, not necessarily the act of intercourse. And so that's more about how I think of it, because then it can encompass intercourse, but it also includes the wellness of the pelvic floor muscles, the wellness of the organs of the uterus, um, and the bladder and the bowels, and how those operate going forward for the rest of your life. And whether or not you're having intercourse, wellness for the sex organs still needs to happen. And so I've been thinking a lot on how I want to reframe and rename and give people, because I really don't like sexual wellness only being, and it always ends up being just penis vagina sex, that's the undercurrent of it, and I also don't care for that as a definition. And so I really try to think about it as the sex organ wellness and how the endocrine system is being interplayed in that health aspect of each patient.
Absolutely. I mean, I completely understand that. And for me, this is why this is so important to have this conversation as early as the hospital recovery. Like, what is more impactful than losing maybe a large volume of blood that you were not expecting to lose during delivery? That affecting how much your heart is able to now pump however much blood you have, because not everyone, quote unquote, according to our medical systems and protocols, we had that talk last month, but not everyone is deemed appropriate for a blood transfusion after delivery, even though they certainly qualify because they are not even functional enough to walk to the bathroom and stand at the sink and brush their teeth. And so when we're talking about the endocrine system, our hormones, and how well those hormones are able to circulate to our brain, to our heart, to our kidney, to our sex organs, we have to, one, start where that person has been affected the most and how well those organs and those muscles are able to support them in other activities of daily living, which sexual function down the road will be a part of. And so if you're a physical therapist and an occupational therapist in the room, please, one, introduce yourself, right? Tell us where you are coming from, where you practice. And for those of you, especially that practice in the hospital setting, I want you to think of this. When you are preparing a person to go home, what are you preparing them for? Are you preparing them for the next 24 hours when they're at home alone, when they have support? Or are you preparing them for the weeks ahead, for the months ahead? And I guarantee you, if you start to think about their journey, those of you who are interested in return to running programs and to return to activity programs and all the things that we talk about when we feel more comfortable preparing people for, I want you to think about fundamental things that our organs and our muscles, right, need to be prepared for way before that. And so if we're already down the road talking to athletes in terms of what they're preparing their bodies for, I want you to think about, well, taking a step back, is that person even having enough energy to stand in the shower after losing a considerable amount of blood after a C-section? If they're not able to stand in the shower, are they able to, one, have the ability to not hold their breath and bear down having a bowel movement? And just scale back with all the functional things that we are more willing to talk to people about. And if you're not able to see that all of those activities fit so closely with their identity, then maybe, yes, this is not a conversation for you at this time to have with someone in the hospital after birth, because sexual health is very much a part of their identity. So, Abby, I have a question for you. I had a patient who was in the hospital after a grade 3C tear. You and I know what that is. I mean, you're right at 4 at that point. She's a professional rock climber, and her spouse was in the room, and she was not comfortable having this kind of conversation with him there. And she made that very clear to me because I asked her. And so, in your opinion, having a conversation with someone who's already thinking about how now their function is going to be affected, especially the activity that they professionally do, how would you introduce a conversation about sexual health with that person?
Where I start a lot of those conversations are with something that's more familiar. And we talk about, I introduce it as, and kind of briefly say, the placenta was providing the hormonal stimulation. You now, in the postpartum period, whether you're a lactating person or not, you have this drop off of estrogen. And if you're going to be breastfeeding, chest feeding, nursing, then the estrogen is going to continue to be blunted for usually at least 6 months. And that is going to suppress estrogen and your period. And I say this, I say it exactly like this, which basically means that you're pseudomenopausal until you get a period. You can ovulate, but you're not going to get a period until you're either if you're nursing until that energy deficit catches up, which is around 6 months, where the needs of the infant top out at about 32 ounces and their stomachs are large enough to intake that. That's usually max out. So we start with the science of newborns. And typically 2 to 3 months after that is when you start to see a menstrual cycle be reintroduced. Not always. And it can come sooner, which is why we want to talk about um, an option for birth control at, thinking about that maybe now, but definitely at 6 weeks at your 6 week appointment. But knowing that about 60% of people do not come to their 6 week appointment for all of the reasons why we know. Um, I want to have that conversation then now because I want to remind them that the old wives' tale of you can't get pregnant while you're breastfeeding is not entirely untrue, but it's also not entirely true. And here is why: you can ovulate, you can have a period before that 6 month time. Um, I've had patients who have gotten pregnant before that 6 month time, even though they had all this information. But I want to give all of that information up front. And I want to talk to them about that, especially if it's someone who's saying they're a rock climber, they're an athlete, they're used to training at a different level. Then I say you're pseudomenopausal, which means that all of the things that you hear about your mom or your grandmother experiencing during menopause, hot flashes, glands dry up, eyes, nose, mouth, vagina, um, bone density problems, muscle mass problems, that's all happening to you right now. So if you feel weak, it's not just that you had, a long uh, period of delivery. It's not just that you're exhausted. You're literally going to lose muscle mass like you had gone through menopause overnight. And that's not your fault. And, these things can be trained back, but this is why it's going to take a longer time for you to recover. This is why part of the reason why you're going to feel exhausted. This is why you're not going to have a period. This is why, even when you get cleared for intercourse, you're going to be dry. It could be painful, but here's what we can do. We can prescribe topical estrogens. Everybody gets a lube, water-based lube. Don't recommend the silicone-based lubes for a postpartum patient. Um, and I always say to this to my patients to sometimes gauge what their intercourse thought process is looking like. Is I say, you should really make your partner work for it. You should be very well aroused if you are going to branch into intercourse, because it will help. It will be helpful for them and helpful for you. Um, and that's usually kind of like a lighthearted way to say that, you should be stimulated, you should be aroused, you should use lubricant, you should have estrogen on board because it's not happening inside your body. And so all of those things, I always come back to science first. And the science of hormones is very specific, and people understand what menopause is, what the menopause symptoms are. And so when you put that in their brain, they kind of flips a switch and they say, oh, that's the feeling I've been having. There's a reason for it. And I think it's important to give patients that reason for feeling that way, that it's, you're not, even if you're aroused, you still might be far too dry. You might need a lubricant. And so, and also when my patients say, I don't feel like I want to have intercourse, I'm like, yeah, you're being sleep deprived. It's a form of torture. You don't have estrogen in your system. This is not going to make you feel happy. So these are all things that like kind of make them say, oh, wow, it's not me. And so they don't take it personally. So I think giving them the science really helps to take that burden from them, as though there's something wrong with them or their partner or their relationship with their partner. I I can't stress enough how validating it can be to hear science back up what you're experiencing. Um, and I think for that, I think that's a really empowering conversation to have with patients in the hospital so they know what to expect. Because when we see them at 6 weeks, or like you were talking about seeing someone years later, I can't tell you how, when I'm listening to a story, how many times I think, oh God, I wish I saw you in the hospital. I wish I saw you at your 6 week visit. I wish I saw you so much sooner, because everything that you've been experiencing up until now, you feel like you've done to yourself, and it's your fault, and it's not. And I think taking that burden from a patient is important by empowering them with science.
How much on their mental health, how much impact do you see this having by having that kind of conversation that early on?
They always cry relief. They always cry when when I hear a patient tell me something, they say, "Well, did I do this? Is this my fault?" Or I can hear them blame themselves for some aspect of what they're experiencing. A lot of it I come back to and I say, I come back to their birth story, because I always want to listen to their birth story. I love listening to birth stories. It's one of my favorite things about the job, is to listen to birth stories and visit babies. These are my favorite things to do. Um, because within that birth story, if there is trauma, if there is prolonged labor, convert to C, and they weren't prepared for any of it, or if they felt disempowered, um, they'll blast truth through their story quite quickly. They won't want to tell it in a long form. And so then I know that there's trauma there. And even if I don't get more information, I always want to pick out something and say, that wasn't your fault. How this happened, you didn't do it. And it can be different if you want it to be next time. But I always I want to take that from them. I want to take that burden from them, and allow them to feel validated, especially if they're going through birth trauma and they felt that their delivering OB was didn't do what they wanted them to do, or they were too aggressive with an approach, or something happened, I want to tell them that it's not all OBs are like that. I could recommend someone else. You're here now and you're doing the right thing now. What you did wasn't your fault. We're going to get you through this. And sometimes it's saying to them, you had a traumatic delivery. Birth trauma and PTSD from birth trauma is real. What you're experiencing is traumatic. It is just as traumatic as everything else that you might experience PTSD from. Birth trauma is real. You're experiencing that. And I want to make sure that we get a mental health professional on board with you to process some of this, because I hear how quickly you're going through your story and how you don't want to be in there and reliving it. And that's okay. But at some point, you're going to need to address this with a mental health professional. And I'm not aggressive with it, and I maybe even don't say it quite as bluntly, but once they've told their story, they kind of already know. And so I think validating the story and saying you had a traumatic birth and birth trauma is real, then a lot of them usually start crying and saying, no one has ever said that. And then, then you have the trust of the patient, and then you can recommend a mental health professional. Um, but they always cry because no one has listened to their story yet. Their relatives have listened and they want to hear the good stuff, but they don't want to hear any of the traumatic parts. And the patients don't want to tell it to their, because they don't feel safe. And I always tell them that it's a rare occurrence that someone doesn't cry in my office in their initial evaluation. Extremely rare.
I want to talk a little bit more about this. I have found that I could not continue practicing and having those conversations months down the road. And I also have to confess that it's been really hard for me to teach acute care therapists to fit their current practice around this population.
Mm.
It's not, you know, new to know that I teach acute care therapists to treat this population like they would after, someone with a knee replacement or a hip replacement. But then I found that these stories take time.
Mm-hmm.
And I would never want to send someone in a room thinking they're going to do a 15 to 20-minute eval, just get someone out of bed and walk, who just had a traumatic birth, and blow through that story because they have another patient on their caseload. And so
Mm-hmm.
I've been for at least six solid months questioning a lot of what I'm doing and realizing, as an acute care therapist, I never treated anyone like that. I never treated them in 15 to 20 minutes because I wanted them to tell their birth story because it was so real and raw. And I realized if I didn't allow them to do that, we're talking about sexual health and identity tonight, they would become the patient that I saw in my outpatient pelvic health practice, Abby, who now was lying down and waiting for sex to be over. They would continue to be that same person who did not have control over their situation. And so I had to somehow in my practice restore their identity, which also included their sexual health, as
Mm-hmm.
early as the hospital stay.
I
Yeah.
would go so far as to say that you might not see them in your office if you gave them that 15-minute visit, because that was their introduction to pelvic floor PT or acute care or postpartum PT. And it would be so underwhelming and so run of the mill that they might not seek it out again, which is my concern with how the time frame works in a hospital for billable units. Um, Even though you can loop patient education, gait training, bed mobility, you can code for all of those things, and it's a pretty big visit. Um, but you're right, the story it just takes longer. It just and it needs to be told in order to best serve the patient. It's just as important as reading the post-op report on the patient, only it's the patients are awake, so they can tell you what's happening.
That's so true. You can read the post-op report and you can also give that person time to tell their story. But then we're sending people in the room that don't have the science behind hormonally what has happened to that person.
Yes.
Hormonally, what's happened if that person then has a Nexplanon insert, that could be given during their hospital stay before their discharge, which is birth control. And they may not know hormonally what is going to happen within the next few weeks to a few months with that person to even know that them getting them up and walking is a drop in the bucket of the kind of care that they need to succeed. It's a drop in the bucket. If that is what your goal is as a therapist treating this population, it would be best to move on. And that is something I don't think I've ever publicly said. And I think it was honestly teaching DPT students for about 13 months that made me realize no, we can give the entry level education. You have to want to serve this population. You have to want to do a little bit more digging, a little bit more education to realize the scope of what perinatal health means, the scope of how underserved this population is, to find the resources for yourself to give that person the keys to succeed during their postpartum recovery. If you're thinking that your standard level of practice is going to match the needs to this population, then I've been a disservice to you.
Well, and there are there are so many specialties and residencies um and even, I mean, when you're working on like, for example, when you're working on the cardio thoracic intensive care unit, you have a specialty training, a specialty certifications that people go through to work on those floors as a physical therapist. I was there as a student and I like observed, like that was not a place that I did anything. Um, and I think that we need to, as a profession, we need to realize that this is a specialty that is starting in a hospital. It's not starting at home. Every postpartum story, I mean, birthing at home is a thing, but it's all happening from a place of where all other medicine is happening. I mean, there are ACL protocols, there are TBI protocols, there are SCI protocols, there are knee replacement, shoulder replacement, hand surgery protocols. And those are all studied and learned by everyone who's on those floors. Anyone who works on those floors has a protocol that they have either developed themselves, that they have that in their brain, that they have put down, that they are teaching to students who are coming to observe. I just don't see why it has to be any different. I don't see why we don't have a dedicated PT OT unit on postpartum floor. I don't see why. We're on the med surge floors. We're on the cardiothoracic intensive care unit floors. We're on peds. I was in the psych ward treating patients. Somebody explained to me why in a level 1 trauma hospital where I was a student, why I never went to the maternity floor. The one maternity patient I saw came to the acute care because um she had a stroke during delivery, um because she had DIC. And so that was the one postpartum patient I saw. And when she came to the acute care floor, people were like, I don't know what to do with her. She's had a C-section. I was like,
Wow.
I'm sorry. You don't know what to do with a person who's had a C-section? I mean, it's a stroke patient and an abdominal surgical patient who also needs a hospital grade breast pump, and we need to wheel the child over. Like, my mind was blown at how unprepared it was, the floor was. It's just, I think we need to get away from, maybe you've heard me say this before, Rebecca, so I apologize if you've heard it, but I don't know how many people have heard me say this before. I'm so sick of people saying it's a natural thing. It's the most natural thing in the world. I mean, okay, we know uteruses are sometimes they give rise to fetus, birth, all that stuff, but um there is there's a whole host of things that happen that are a cascade in the body that are part of the course of postpartum, but it's not a part of it is the lack of support that we get at home. It's not the lack of support that we're getting from our workplace, the lack of support, the lack of family that's around to support. That's not natural. So we can't do anything that's natural. When we get home, we have to do everything because you are not releasing that person home to take care of just themselves. Typically, you are sending them home to take care of a newborn, and that newborn, that person is going to prioritize pediatrician visits and not go to their own visits. They are dropped off of the face of the planet of medicine. And that postpartum floor, where they are under a doctor's supervision, where there are nurses there, where there is a nursery where they can send that baby when the baby's sleeping so that they can get some much needed rest, where there's a lactation consultant, there should also be a PT there, because like you said, their sexual wellness and the wellness of their organs doesn't end there. They, which is maybe also something that people assume, is that like they are no longer sexual beings because they are now mothers or parents. Like maybe that's the problem. Is that identity is now taken away because they serve a different purpose. But I digressed and say that with all of the support that's there, why are we not there? I don't understand it. You're having abdominal surgeries, you're having major medical events, you have, the hemoglobin hematocrit, it could be tanked. We're talking about, in the 4s and 5s.
Oh, yeah.
And like the 30s. And these people are expected to get up and take care of an infant and breast chest feed. Are you out of your mind?
Oh,
And
absolutely.
also their brains are not functioning properly because they don't have some more hormonal support. And we got to stop calling that mommy brain and baby blues, because it's not. It is postpartum depression, anxiety, and psychosis. And it is estrogen depleted brain function. And the more we can put the science into it, I think the more that there is no longer a reason why we should not be on those floors. You cannot make a case for us not being there when you're looking at it scientifically. You just can no longer make that.
Rebecca, can
I
this is Josie, I was wondering if I could say something. My phone's about to die, but I have something to contribute along with Marcia, who I mentioned to you before. If that's all right, if not, I will rescind my hand. I'm sorry.
Absolutely. Josie is with us, joining with us. And Abby, I think this is important to just introduce her to this discussion. She's an occupational therapist, and this is why we have these individuals with us discussing people's identity and their wellness. Please, Josie, if you can just turn your camera just the other way so that we can get a.
I'll try to
Yeah,
include
that's
both
fine.
of us.
Please introduce.
Perfect.
Hello.
Thank you so much for welcoming me here. I hope my phone doesn't die. So thank you for this intrusion a bit, which these are inconvenient challenges that women exist and marginalized people exist. And in theory, they might have rights in some cultural contexts. And that is sort of certainly the goal. With that lens of identity, I wanted to bring up that identity is very important, and we have to take into account the historic context that developed the initial seeds and roots of the United States-based social and healthcare system, which is foundation in fundamentally and systemically sexist assumptions about human development, as well as systemically vital, if not genocidal, approaches towards indigenous populations and towards Black people in particular here in the United States, as a legacy of the systemic neglect of human rights that resulted from the systemic enslavement of individuals of color and a caste system that perpetuates in the United States social services to this day. From what I have been able to observe as a policy analyst within the occupational therapy profession, somebody that's invested heavily in understanding the history of occupational therapy and the social movements that gave rise to occupational therapy before the United States healthcare system, I just wanted to express that Medicare, which tends to be the default payer for both acute care hospitals and third-party reimbursement payers, I've seen multiple different Black and white text that substantiates that Medicare does not discriminate on the basis of diagnosis for access to services such as physical therapy, occupational therapy, speech therapy. Yet what I'm hearing from this call here and what I've observed as an acute care therapist and a post-acute care therapist is that discrimination on the basis of identity, by skin color, by sexual identity, by gender are active and aggressively maintained by our current contemporary healthcare system. And through definitions of triage, not only are our disabled brothers and sisters being systematically deprived of essential healthcare services and the bare minimum of standard of care, but even typically developing and fully functional adults and individuals that happen to have intersectional marginalization, whether it's by class, race, incarceration status, standing, and in particular, women of color, and in particular, Black women in the United States are currently subject to inhumane treatment as it relates to the reproductive system. This is something that I'm excited to partner with allies such as Rebecca Seagraves and those that are on this call. I'm here with Marcia Carter Patterson. Marcia lost her son to systemic injustice and harm here in my local city of Tacoma, Washington, 3 months prior to the loss of George Floyd. And
it was during the same month, 3 weeks.
She's almost lost an additional grandson just in the last month due to medical negligence and access to standards of care of what we have discussed here, including manual use without gloves and refusal to take vitals at an emergency room setting. And we are working together to bring visibility to these causes. And I just wanted to add that to the conversation. You cannot understand contemporary triage and honestly, things that almost verge on maintaining systems of eugenics in the United States without taking into account the broader historic and socioeconomic context of the current profit-centered and care denial-centered aspects that are foundational to the U.S. healthcare system. I do believe that therapists can and should play an active role in bringing visibility to these discriminatory practices and medical negligence that are systemic. They're not the faults of any individual clinician, but a part of a system that we all work in together. And our voices, I think, can be a power part of making sure that these marginalized populations are not alone in accessing the essential Medicare that they need, not just for pregnancy, but for every vital life risk of fatality. We need to have equitable care. And my wish for this community is if we start at the root, if we start at the pelvic floor, may every other systemic injustice have a pathway towards resolve. Thank you for including me on this community. I just wanted to add that broader context to the conversation and how important it is therapists have always been on the front lines of social justice causes and advocating especially for the disabled, which often pregnant women can be at risk for disability with these complications and their mental health, systemic mental health neglect. So I just want to honor and recognize that you're doing important work. While I haven't been in the pelvic health orbit, I'm a lifelong advocate for these communities. And I think that what is developed here can have great transformative potential to bring alignment of our healthcare system with many of our professional associations' stated values and concerns by diversity, equity, inclusion, and justice. Marcia, did you have anything you wanted to say?
I just wanted to really quick talk about my daughter that right now, she's experiencing pelvic health issues, and without occupational therapy or physical therapy, she's doing this all on her own, having a newborn baby and 6 other children and a husband that she has to provide and take care of. She had to go home from court today because she was in so much pain. So,
and this is also while she's navigating the potential of backlash with a nationally recognized trial for defending the loss of her brother's life. So I do know that we have consent to bring visibility to this causes formally with your daughter, and I am helping to be a point of care advocate to make sure that we can try to find access to the essential services for her recovery so that Marcia does not lose another child to the systemic. My phone is about to die, but I'm sorry, is there anything else you wanted to say?
no, that's all. No.
Marcia,
thank you all
if your service holds out, if you can say one thing to therapists who are encountering barriers to providing their services in the hospital to women like your daughter, or even knowing, I am so sorry about your son, but if there's something that you can say to change our minds about our role in this crisis, what would it be?
I mean, I heard that there's a therapist on every there's lung therapy, you get OT, you get PT, surgical therapy, OT, PT. How come there's not therapy on those pelvic interventions or those floors after childbirth? Why not? What's holding the systemic or the system back from bringing this therapy on to women that truly, not only Black women, but women that need this service? When you have a C-section, I had one. I didn't know what pelvic therapy or occupational therapy or physical therapy was. And I needed it because I was sick after that. My daughter was in the hospital for 3 weeks long. So it's needed. How do we go about bringing in knowledge, awareness? How are we going to get the needs met of these women that are going through C-sections and having these difficult births with occupational, physical therapy? I mean, particularly, I'm just going to say occupational because that's what we're addressing right now. But how are we going to? So that's my tone right now, and that is where I'm at. I want to see my daughter get occupational therapy right now, physical therapy right now, so she can start to feel better. Because you even address postpartum depression. Call it what it is. It's not somebody that's just going through because they just had a baby. It's postpartum depression. She's depressed. She has anxiety. All of the symptoms that you guys
not to mention the grief from the trial. Part of it too is your daughter is an inspiring civil rights activist, and she is somebody who's not held back in speaking truth to some of the most terrifying power holders in our community. So she's braced for backlash. That's one of the things I wanted to add to this conversation, that women of marginalized status and identities, when they show up and they advocate for themselves in these systems, they can be at risk for experiencing violence and backlash. And that's something that we need to be mindful of as healthcare advocates and licensed professionals that we need to lie with our patients and not leave them alone when they're in a vulnerable position.
And that's where she's at right now. She's got 7 children. She has to make dinner for. She has to make breakfast for. She's traveling from Lacey to Tacoma every day for a trial. How come she can't have a Airbnb? Why aren't there
a village? Why isn't there a village?
Where are the activists and where are the people that are on our side? I mean,
it's not just for the loss of life that we've experienced from Black Americans subject to systemic harm. It's also about the lives that are not adequately supported.
And somebody else could have it. Another person can have it. But why can't we access the system in the same way that that white counterpart is accessing the system? Yes, it's about a racial. It's racial. It really is. Because it's a disparity.
If you can only access healthcare services through publicly subsidized programs, how really is pelvic floor healthcare going to be accessible?
And you're not going to get the best public health care that you can get if you're accessing it through a lower income status. And we know that.
And we know incarcerated women are just even more unlikely to access this level of care.
For the record, will you say your son's name?
Manuel, Manuel Ellis.
And Manny Ellis is kind of the one that they would search for on Google.
So you would go Manny and then Ellis, Manny Ellis.
There's a wonderful podcast documenting what our community has been going through in the wake of his unjust passing.
It's called The Why.
I'm so sorry for his story being lost in George Floyd, but I remember Manny Ellis.
Thank you.
Story.
I'm going to share in the chat before my phone dies an event that we're organizing together, and likely Rebecca, it sounds like she's going to help me prepare with Allison Sover, AHA president, a statement of solidarity with Black women that are experiencing public health discrimination in acute care in a variety of different contexts. With your blessing, Rebecca, to share this. But we have a virtual event that will be accessible for folks that want to be part of this conversation and bringing these to light, especially through community art.
Thank you so much for both of your work. Thank you.
I will send the podcast in the chat as well. And just forgive me, it's going to cut out at any time, but thank you so much for this opportunity, Rebecca.
Thank you, Josie. How did that make you feel?
I mean, it's maddening. I hear that story, and I saw that story when I worked at a hospital here in New York, because it was very clear the socioeconomic status of the patients played a role in even how many days they stayed at the hospital postpartum. I have, friends who have delivered it at all of the hospitals here. The hospitals have been changed over, they've been bought, they've been sold, they've been merged. But the hospital I'm thinking of is the Level 1 Trauma Center down in Brooklyn, and socioeconomic status plays a huge role in access to healthcare. Full stop. Period. End of sentence. I would go so far as to say that pelvic healthcare is non-existent for postpartum patients who have Medicaid, or who are using social services. I would say it's non-existent. I don't know a single pelvic health therapist who takes it. The reimbursement being what it is. And without it being offered in hospitals, it would be something that there would be no access to it.
I agree.
And, I echo the sentiments of why isn't it in the hospital? Mm-hmm. It doesn't matter if you have Medicaid or Medicare. If you've had an ACL surgery, you're going to get seen by a PT. You're going to be given a home exercise program. You're going to be given a protocol. You're going to be signed up for post-discharge PT appointments. Like, end of story. And not for nothing, that's an elective surgery at this point, as the literature is coming out to say that ACLs repair themselves quite often. And unless you're a high level athlete, it's sort of an unnecessary surgery. We keep coming back to that, but let's not let that get lost into it, that it's an elective surgery. Childbirth not being elective in most of the United States of America now.
Well, you're true, but it's an elective procedure that you can choose to have in the hospital, or you can choose to have it elsewhere. But it's still elective. And the fact that it's elective means there is, in some cases, not really a hard cap as to how much a hospital can charge for additional services. That a lot of people, after being informed, especially about some of the things that you've even talked about, after being informed, they will not argue with could be unnecessary, could be for their quality of life or whatever it is. But in terms of the expense and in terms of the triage and how we prioritize those additional services, we're making a judgment call on what that person will either pay for or not pay for, what their insurance will cover. And then we're deciding whether or not they would benefit from additional education or information. And so to bring this full circle to the topic at hand, Abby, I want to discuss with you as a final topic. When it comes to sexual health, we've established that there needs to be more time than the standard OT or PT visit for this population. We agree on that. By prioritizing sexual health and identity in the hospital, that means that at the top of it, we're going to probably prioritize everything else that falls in the realm of pelvic health. Right. And so, in terms of that, when we're having these conversations, and we just heard that there is a triage and a marginalization and exceptional removing of certain populations from that kind of care, it's going to take a special therapist, if you will, to bring that education and information to the forefront of care, not on the back end, weeks and months down the road when that person is struggling to even walk and function still, struggling mentally with postpartum depression. I'm glad that you're saying that. It's not just baby blues, it's postpartum anxiety, psychosis, postpartum depression. Let's call it what it is. And so to have a conversation about sexual health means you're able to have a conversation about everything that means something to that person. And that's not something that you're going to take in a weekend course. That's certainly not the things that I've actually even covered. What you're able to teach OTs and PTs in the hospital, Abby, I don't think any course is teaching them. And so my most important question to you before you even have a chance to think about it, would you be willing to mentor individuals who want to level up the care that's being provided to this population, knowing the science that you know and knowing the science that even our therapists are implementing? Not saying that they don't know it, they're not implementing it.
Yeah. So my practice being what it is I do mostly home visits. So it precludes me from inviting students. And I've been asked by students who are the initiative that they take in their graduate program to reach out to me because they've heard me speak or they know me from socials, to say, hi, I'd really love to shadow you, or I'd love to do my rotation with you. My practice just doesn't necessarily allow it because I'm going into these patients' homes and they're expecting a certain level of privacy. And so I am always willing to take on in a mentorship role, people who are looking to integrate the global body systems into their understanding of the why of pregnancy and postpartum. And it's one of those things that I really do love to come back to science, because it's it's harder to argue. I mean, when you say something like baby blues, or you say something like leaking is normal, ha 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 ha, or just have a drink before you have sex. Doesn't everybody do that? I don't I don't subscribe to any of that. I really dislike all of those jokes and memes, and I always want to come back to science. And so empowering other therapists to understand the hormonal cascades and understand the implications of that and how it's acting on not only the musculoskeletal system, but the cardiac system, the cardiothoracic system, and the neurological system, and then how that's going to impact the global system's function, I think is really, I think it's one of the most empowering ways to educate our patients to know the why of what's happening, because then they feel like there's a reason and it's not their fault. And I keep coming back to that because so many patients come to me and say, I've done this is my fault. I didn't do enough of this, XYZ, and it's just not. And it's and we have to take some ownership of that failure and say that we're not educating well enough and that we're not educated well enough. So I'm always here for people who want to learn more.
Excellent. And I agree with the comment that was just in the chat saying that the training needs to start in OT and PT school.
So I agree with that, except for that there are certain certifications that exist that people cannot work on the cardiothoracic intensive care unit floor without having a specialty certification. And I think we need to have more residencies. I think we need to have more specialty certifications that take people through these systems. I don't think PT school is enough. I think we need to do residency. I think we need to push to specialize ourselves, because schools are going to focus on, you have to, it's the same way as we look at hospitals, you have to follow the money. With schools, you have to follow the test. The test for licensing is not going to change. That is a big boulder up the hill. I think groups like, there's the WCS with the APTA, and there's there are Herman and Wallace and all these other places where we can get these courses. The very basic stuff, how those questions come through on our licensure exam is that it must be published and it must have RCTs behind it. And those are coming from, Kate Ackerman's group and the group over in Ireland and Scotland who are doing that. There are a lot of people who are doing a lot of great research, but in order for those tests to make it to those questions, to make it to the tests, to make it to the exams, they have to come back all the way back to research and money. And so we really need to get money fed into research. We really need to get people who are passionate about research so that we can have the justification for it. We need to, because that's, sports is the reason there's so many sports residencies is because there's so much money in it. There's so much money in elective sports rehabilitation surgeries. So I think we need to get more research into it. We need to get louder as people who deliver babies. We need to get louder about it. And I think we need to get more money behind the research so we can put the tests on the exams so that we can justify having more coursework in PT and OT school that reflects this. But again, I think those are big boulders to push up the hill. And like Rebecca, you have pioneered this to get into the hospitals now, to see the patients now. And I think the more we do that and the more we can generate codes and justify visits in the hospital and show them on a spreadsheet that we are making them money and they're not having readmits for things like postpartum depression or for infection or for, complicated pregnancies because the births were, less than 2 years from birth to birth. I think the more that we can show those statistics, we have to get into the statistics. We have to get into the money about it, because that's the only place that they're going to see it, is where we can generate them money and prevent readmits.
My nephews, I would say, are close to their teenage years and being driven towards sports. And I know they can barely read above a third grade reading level.
Mm-hmm.
We don't have certifications and specializations and even enough professors in the OT and PT schools that we're graduating therapists from to, one, care about this population enough as much as we do about our athletes. We put so much money into sports and even making such a big bulk of at least physical therapy education. I can't speak for OT education, but we put so much emphasis into our ortho curriculum, way over than we would the peripartum curriculum, even though the most common surgery in the world, major surgery, is cesarean section. We put so much emphasis on sports and ortho is because the population that we're grooming into these areas care about it. We don't have enough people caring about birthing people. And so I agree with you in terms of putting money into, education, in terms of educating our population, because I think that that's going to be a driving factor in what we emphasize on our tests, what we emphasize in our educational systems, what we emphasize in actual practice and patient care. But to say that it's going to necessarily change the tides, I think that's a long game. And I sent out a message recently before our talk, Abby, basically commending anyone who's going after a PhD, anyone who decides to go into academia like I did, thinking they can change things upstream by teaching students differently. I commend anyone for getting another certification to teach, or train one person, patient at a time. But if we are not public facing with our message, we are playing a long game, and we're going to undoubtedly not see a change within our lifetimes. And that, I would say, probably makes me a little bit different because I don't want to wait that long. I don't want to have another podcast or interview or webinar that I either am a guest on or that I'm hosting on, where someone has to feel like they're breaking in and interrupting the flow of the conversation to tell a story as dramatic as the one that we heard tonight. To basically have to advocate for a person who could not be on herself to tell her traumatic birth experience. I want that story to hit home to the public, to be educated to the public, so that they're walking in and they're not leaving until an OT or PT is in their room before they are discharged from the hospital. And an OT and a PT that's qualified to be there for the time that's needed to cover all aspects of their function, including their sexual health and wellness. And until that gets across to the public, I don't know that teaching it in schools are going to make a difference. We're putting out certifications, and I'm guilty of that myself. I went to the therapist first, and what I should have done with ERAD was went to the public. I should have been teaching the public the importance of advocating for their own care. And so this conversation, I think, is important on several levels because we're talking about what we should be doing. But lastly, what I want to hear from you, Abby, is what should people know before they even choose to give birth in a hospital? What would you want that person to know before they even walk into a hospital to have a baby and before they leave?
Oh, before my patients go in, we have a long discussion about options that they have and who is going to be their advocate in the hospital. And I say sometimes your advocate is not your partner because they feel embarrassed to chase people down the hall if you need something, which I've done myself, is to go over the charge nurse, to go directly to your surgeon, to ask for your surgeon's phone number. I mean, these are things that I always encourage people to do is to discuss prior to getting in there, discuss with your OB if you've been seeing, hopefully you've been seeing an OB regularly in the last trimester of pregnancy to discuss with them what parameters that OB has for converting from vaginal to C, what parameters they have for whether or not they use forceps or vacuum, who could potentially deliver you, to meet everybody and to understand their parameters for those things, because I find that in those transitions during delivery is where the disempowerment of a patient happens. So I think if you understand going into it, yeah, I'm going to let you push for 2 hours and then I'm going to call it, because 2 hours is the demarcation where we start to see detrimental effects to the birthing parent. Whether or not the fetus is tolerating it, it's a demarcation. Or is it 3 hours? Is it 4 hours? I've seen a lot. I've seen people arrest delivery for an hour and let the fetus sit in a canal for an hour because the OB is down the hall and not ready to deliver you yet. I mean, I have seen some things. So I think having that conversation and then saying, I always let them know, here's where my recommendations are with effacement, with station, with how long you push for. Here are the types of inductions you can have. Here's what you have a right to ask for. You can have an epidural and still turn to your side to deliver. You can have an epidural and have it turned down so that you can feel contractions when it comes time to push. These are all things you can ask for, but you just need to know that you can ask for them. And you kind of need to let your OB know that you know, so that there's a leveling of a power structure there sometimes. So we go through all of those options. And then we say, and I always remind them that if you're going to get an epidural at any point, it's going to be a sterile procedure, and they're going to ask your partner, whoever is in the room with you, to leave because it's a sterile procedure. And that can sometimes be very traumatic for patients, especially if there's an emergent situation, is that they're going to roll you, they're going to put it in, and no one's going to be there. And I always say, you ask them to give you the nearest person to hold your hand if you need a handhold. I always needed a handhold. I've had like 7 epidurals and I'm always needing a handhold. And sometimes it's the med student and they don't really know what to do, but you say, give me your hand, I got to hold it. But your partner can't be there for it. They won't let this, they'll bring them in after as soon as they can. But that's sometimes very jarring for a patient who's just gone through a lot and who's now converting to a C. And, talking about C-sections, how they can have a curtain, they can have skin to skin if the baby is okay, if you are okay, that it's a longer process to get stitched up than it is to deliver the baby. So you're going to be there for a little while. You might feel nauseous. This is why your blood pressure might drop. There's nothing wrong, but let the anesthesiologist know. All of these things that are like, give you the option to say, oh, I can talk to the anesthesiologist. Oh yeah, they're up here by your head. They're the one who's there. Let them know if you're feeling terrible. You can ask for skin to skin, all these things. And then in the postpartum, how long is it? Warn them how long it's going to take for the epidural to wear off. It's about an hour, but it could be sooner. It could be one side more than the other side, just depending on how it was put in. That how long can you, are you going to wait for your bladder to wake up? That I always recommend asking for Miralax and not a stool softener, because I think stool softeners are ineffective when you're talking about passing a stool that's got, when you've had narcotics in your system. That I think, Miralax is a better choice to soften it. I don't think stool softener is very helpful. All of those things. And then that I always say that even if the signs in the room say baby should room in with you, there is just absolutely nothing wrong with sending that child back to the nursery. Nothing wrong at all. If you want them there, great. If you need some rest, send them to the nursery. There's nothing wrong with you. If you're having trouble with pumping or latching, or ask for a lactation consultant if they're not offering you one. And then we always talk about the possibility of a C-section. So then we're always talking about that you will need someone to show you how to roll in bed so that you can stand up and get up. Don't do it by yourself. and that you won't be able to stand up to get the baby from the bassinet. So you'll have to call the nurse. Don't feel like you're bugging them. You will need help. And then talking about all of the postpartum stuff, all the bleeding, how long the lochia can last, that it should diminish over time, what side of a clot you should look at. And here's where I want to say that if you have ever found yourself, as I have, saying, well, it's not that important, I don't really save lives, it's actually not true, because I have saved the lives of my patients postpartum, because they had my cell phone. And in the weeks that they couldn't get a hold of a doctor, or they were turned away from an emergency room when they had a fever and mid back pain, that they called me and I said, don't go back to that hospital, go to this hospital and tell them what you're experiencing. And that patient had remnants of conception and was septic. I did save that patient's life. So please don't diminish what you're doing and saying, I don't save lives, because you can and you will. If you are in this profession long enough, you will. And your patients will experience that if you have a patient who has high blood pressure and is preeclamptic, you can be preeclamptic postpartum too. The pre has nothing to do with pregnancy. So these are all things that we know, that if we have a high risk patient, that we can inform them that if you have a headache, if you feel heart palpitations, if you're feeling lightheaded or dizzy, that I don't want you to ignore that. I want you to call me if that's who you feel comfortable calling, but then I want you to take yourself to an emergency room, and I want you to be seen, and I want you to refuse to leave that emergency room until something is resolved, until you are seen by an attending physician, not that they have signed off on your chart, but that you have been seen by an attending physician. And so we go through this whole thing. And sometimes if a patient doesn't seem like, if they seem like they're nervous about advocating for themselves, then I let them know that I lost a friend to a strep B infection in a major hospital in a big city when her father-in-law was a physician and she called him too. It can happen to anyone. And I do stress that with my patients, not to scare them, but to let them know that, 7 years ago, we lost my friend completely unnecessarily. And that advocating for your patients and empowering your patients might save their life. And that you might be the only one who listens to them and who hears that red flag that doesn't sit quite right with you, that keeps you up at night, that you say, I got to come back to that. You might be the only person they've told that to. And then you can flag it for them and let them know you need to take yourself to the emergency room right now. And I always say, if you need to get me on the phone with the doctor, take your cell phone, give it to the doctor, and tell them that they need to speak to me. And that you are no less their doctor than their OBGYN in that moment. You are no less their doctor than their GP in that moment. You are no less of a doctor. You are a health practitioner. You are their advocate in that moment. And so when you're telling your patients all of this information in their visit, wherever you're meeting them, meet them where they are, but give them the science, give them the facts, because you might be the only one that they are hearing that from.
To the OTs and PTs in the room who are with us tonight, who are acute care therapists, who do not feel that you have a voice in your hospital system, I want you to replay that last part. I want you to listen to what Dr. Bales is telling you tonight and give it time to sink in. You are in a position to save someone's life. You're not only in a position to enhance their sexual health and wellness, which was the topic for this evening, or to prioritize their identity, or to maximize their quality of life into the postpartum recovery period. We're talking about saving someone's life, preserving their mental health, and preserving their physical function. Dr. Bales, how can people get in contact with you who just want to learn more, who would be absolutely honored to be under your care, but who also want to follow you for mentorship?
Yeah, you can reach out to me on Instagram. You can DM me. I'm at Reform PT NYC. No spaces or underscores, just all straight through. You can also just email me at info@reformptnyc.com. Um, and I love to hear from you. I love helping other therapists enhance their practice. And yeah, if you have any questions or if you have a particularly difficult case, um, or if you need to just learn how to yell at people at hospitals, I'm a good one for that.
Thank you so much.
My pleasure. So nice to see everybody. Thank you for having me.